All right, so thanks a lot for coming. Thanks a lot for taking a couple of minutes to listen to what we do and to watch a couple of examples. My name is Georg Langs. I'm from contextflow and also from the Medical University of Vienna. A few words to contextflow. We are a spin-off of the Medical University of Vienna, focusing on deep learning methods to analyze chest CT data, focusing on the lung right now. Right now we are installed across Europe. That's a little bit out of date, so we are now in 12 countries, so also France, Belgium and Switzerland. And Denmark joined very lately to the places where our software is installed. We are processing about 10,000 cases each month as part of clinical routine, where users use the software in order to understand better what's happening in these cases. And so what we do, and I think most of the talk will be about examples to kind of illustrate what the software can do and also where we view the field of artificial intelligence and the benefits of artificial intelligence in medical imaging are going. There are a couple of points where AI can help and where our software is involved. So one is, and I highlight a couple of points. So one is in workflow. We can detect certain disease patterns, and that helps in sometimes routing cases to the right experts and sometimes kind of ranking cases so that for the right kind of urgent findings, downstream actions are taken. Automation is one part. It sounds a little bit boring, but I think still it's relevant because it takes work away by detecting lung nodules, performing measurements that can then go into guidelines and can go into decisions that are taken by radiologists. Quantification is something that I'd like to talk about today. The capability of quantify the amount and the distribution of disease patterns and also track that over time and understand what these changes mean for the future of the patient. And I think all of that feeds eventually into diagnostic support, where we use what we see in the imaging data and quantitative profiles of these patients in order to help diagnosis but also help treatment decisions based on predictions about the future of the patients. And I'd like to illustrate it in a case of diffuse lung diseases, of ILDs, interstitial lung diseases. They are really complicated, big family of hundreds of diseases that are difficult to diagnose, where we have kind of only starting to understand what is in the lung means for the future of the patient and for the response to a certain treatment. And the difficulties are coming from 2 points. One is that the patterns in the lung are really hard to interpret. They are hard to understand and hard to kind of classify for radiologists. And the second one is that it's hard to make these connections about what is in the lung right now and what does that mean for the future of the patient. There are really interesting publications and also studies about kind of how well that works when you do it manually by looking at the scan. So this is a paper by Simon Walsh and his colleagues where they looked at the consistency of readings and consistency of diagnostic decisions across different experts, and it turns out that it's only really moderate. So that is something where we would like to improve the capability to be consistent and to be accurate in figuring out what is going on in the lung. And I'd like to show you one work by Jenny Pan that was published this summer, and she looked into how we can use machine learning, especially unsupervised machine learning, to figure out what type of patterns are there in large populations of patients, use these patterns and figure out which of these patterns are linked to disease progression, and use this information in these models that are able to consistently track and identify different disease patterns over time to build kind of dynamic profiles of what's happening in the lung. So what you see here is basically a labeling of the lung into different disease patterns, and once we look at this progression over time for individual patients and then build a model about what's happening in an entire population or what's happening in different disease cohorts with different diseases, we are able to kind of understand the progression of the disease and also to predict something about the future of the patients. And this is really what I'd like to talk about today, to say, well, if we are able to quantify what's going on, if we are able to observe in large populations how what's happening in the lung is connected to what is going to happen to the patient, we can use that immediately to predict, and this is a case where in IPF patients we can predict outcome, we can predict the risk for these patients fairly early by looking at these quantitative profiles and especially the dynamics in these quantitative profiles. But the second thing, which I think is also important, that we can now also use this evidence that we are collecting across large populations to say something about the dynamics and the mechanisms of the disease. So we are able to say, well, we are not turning from healthy lung tissue to completely diseased lung tissue, but there are actually a couple of pathways that this disease changes the tissue along, and where we might have a couple of points of intervention where treatment might change these trajectories or might make them stop and not progress the disease. And so in our case, that means we would first translate a chest CT into essentially a picture of what type of diseases are or disease patterns are happening, how much and how they are distributed, and then in a second step track that over time, because now we can look at that over time, we can match the cases, and we can tell something not only about a single time point, but essentially about the history of these diseases and how they develop over time. And now I'd like to spend the remaining time to show you a couple of examples of studies that were made using these algorithms and made using this software. So the first one was also published this summer in European Radiology by Sebastian Röhrig and Helmut Brosch. And they looked at the first most simple question, which essentially is, if you are reading a CT and if you have a tool that allows you to just click at the position and the tool tells you, well, that's this pattern and that is this pattern and that is the evidence and that's the relevant differential diagnosis, does it improve your reading? And the study was fairly straightforward. So we had 108 cases of different diseases, different ILDs. There were 8 readers, 4 junior and 4 senior, because we were also interested in the different effects that would have on more experienced and less experienced readers. And each of the readers looked at 27 cases without any support through software, and at 27 cases where they had the software that basically allowed them to look for relevant information based on what was in front of them. We looked at diagnostic accuracy, timing, and differential diagnosis accuracy, and there are a couple of interesting things happening. So the first interesting thing that happened was when you look at how often radiologists look for relevant information, when they don't have kind of the software, or where they just look in traditional sources like Radiopedia or StatDX, then they search in a little bit less than half of the cases. But if you give them a tool where this search becomes really fast and efficient, they search in many more cases. So they just search more often, which also means that they have more evidence and more kind of basis, a better basis for the decision more often. The second interesting thing is that even though they searched more often, overall they took less time to read these cases because the search was just faster than the search they typically do. And if you do the statistics, it basically comes up to about a 30%, 31% time savings per case if you use an efficient way that tells you, well, this pattern is likely that specific pattern, and this is the evidence, and that's the relevant differential diagnosis. So now let's look a bit under the hood and let's have a look at how well the segmentation and the identification of these patterns look like. So this is work that was shown at ECR this year, and essentially the experiment was when we let different readers segment really difficult patterns like honeycombing and GGO in cases, and then they all run through a quality control loop, basically something that you cannot do during routine reading, but that you can only do in a research setting where you have a lot of time in really doing exact delineation. How well does an algorithm fare with segmenting these patterns in these patients if the algorithm is trained on a different patient population? The agreement of the readers is about 0.77% or 0.77. Again, these are two raters that did the delineation and went through quality control. The agreement of the algorithm with these readers is in about the same kind of order of magnitude. A little bit better, but essentially on average the same. That means with an algorithm you get about the quality of segmentation of these patterns as if there were an expert sitting down, delineating these patterns and then going through a quality control loop. So I think that's pretty relevant. The second thing is we looked at how patterns, deep learning can help us to do a better job at segmenting these patterns, and this is an example of emphysema segmentation, where we see that when we use pattern-based emphysema segmentation compared to just Hounsfield unit-based pattern segmentation, that we get a bump both in the positive and the negative predictive value of detecting these patterns, of detecting emphysema in patients, which is relevant in the context of COPD. We pay with a little bit of a loss of sensitivity, but we get a huge boost in specificity of detecting emphysema. Right, so the segmentation works quite well, but now let's put it all together and see what we can do in terms of prediction if we use this disease profile. So essentially if we say, well, we predict and we segment these patterns, we get a quantitative profile of what's happening in the scan. We can use that in order to link what we see right now in the CT to the future of the patient. This is a study by University of Cambridge, Medical University of Vienna, and the entire IX-COVNET consortium, who looked at COVID patients and looked and asked, if I take the first scan, if I create this quantitative profile with the software, can I predict whether the disease will turn into a severe disease or not a severe disease? Now you can do two things. You can basically ask how each of these patterns and to what extent each of these patterns is a marker of risk. So we see that GGO, reticulation, coarse reticulation, honeycombing are actually predictors of risk. But we also see that if we don't look at individual patterns, but at the entire profile of the combination of patterns, we get a pretty substantial gain in predictive capability. So here you see the comparison of what if I use just one good marker pattern in order to predict severity. That's the lower part, we get about 57%, but if you use the entire profile of patterns, so essentially the multivariate characteristics of this case that we can extract automatically, we get a pretty good bump in the predictive accuracy. So this is for diffuse lung patterns, and I'd like to close with showing you some results out of a partnership, and these results come from RevealDX. So contextflow and RevealDX are partnering up in order to combine lung nodule detection and lung nodule assessment. So we do lung nodule detection, classification of lung nodules, essentially to speed up and robustify and make sensitive the detection of nodules that are relevant in lung cancer screening, but that are also relevant in finding incidental nodules. But then we add the capability, together with RevealDX, of essentially saying, well, we can assess these patients and nodules following guidelines, but we can use machine learning to be a little bit more accurate and to catch a couple of cancer patients that would have been false negatives, and a couple of cancer patients or a couple of benign cases that would have gone into biopsy and that don't have to go into biopsy because we correctly assess them as benign cases. And I don't want to go into detail. There is a paper in JACR that came out this summer, but essentially we are able to capture false negatives and also to reduce false positives in these populations, and I'd like to refer you to the paper for the details. We bump up sensitivity and specificity, and it's all connected with detection and assessment of these nodules. And so to close, I'd like to show you how that can be turned into a user interface that's actually practical. So this is an example of looking at a case, getting all the disease pattern at once, getting all the nodules that are happening in the case, being able to explore the case in terms of where these patterns are happening. And something that we are introducing right now here at RSNA is also the capability to track changes first for nodules and see how nodules change, how nodules emerge. And I think again that's relevant both in the detection of nodules, but also in how we are able to quantify the response to treatment, how we are able to assess when a treatment stops to work and when we have to switch to a new treatment in cancer patients. And with that, I'd like to thank you for your attention. If you want to have a bit more information, just down this road, there is the booth of contextflow. And yeah, thanks for coming and thanks for listening. Thanks.